Hey guys, good afternoon. How do you feel about the last session, pulmonary pseudonodule? This time we will learn about the true nodule, true lung nodule, solitary pulmonary nodule. Let's enjoy Dr. Y chest radiology. Let's get started. Before entering this new session 33, pulmonary nodule, solitary pulmonary nodule, we'd better review the previous sessions. 13, 1.3, lung cancer in general. 1.5, adenocarcinoma, the lung cancer. 2.0, other lung tumors. 27, tuberculosis. Session 32, pseudo lung nodule on chest X-ray. Please review again and then come back, please. Why do we pay so much attention to nodules? Because we are afraid, very much afraid of getting cancer in our lung. What's the matter with the solitary pulmonary nodule? The incidental findings of solitary pulmonary nodule in asymptomatic people is a common clinical dilemma encountered in daily clinical practice. If the CT image is of yours, your CAT scan, how do you feel? If this 6 mm nodule on right upper lobe of CT and chest radiograph is yours, in my lung, how do you feel? How do I feel? If your doctors in front of you are telling you you have a lung nodule, new nodule, pointing on your chest image. Case 1. If you are a healthy young man, or if you're a heavy smoker of 60s, or if you have been quiet for 5 years after breast cancer surgery. Let's presume the 3 cases. You may feel or respond. A. The young healthy man. What is a lung nodule, doctor? He may become curious, just curious. In situation B, 60 of heavy smoker. Can this be a lung cancer? He may get anxious, very anxious. In situation C, the breast cancer patient may say, did it come back? What is nodule? The Wikipedia is telling us in medicine, nodules are small, firm lumps. Dr. Y, I myself would say a pulmonary nodule is a small, firm lump in the lung. But actually, we include ground glass nodule, soft nodule, as the nodule. So I would delete myself the word firm. So the pulmonary nodule is a small lump in the lung. Pulmonary nodule on the glossary of a Fleischner Society is like this. On chest radiograph, rounded opacity, well or poorly defined, measuring up to 3 cm in diameter. On CAT scan, it is rounded or irregular opacity, well or poorly defined, measuring up to 3 cm in diameter. Mass, the mass is important, very, very important. Mass is rounded lesion measuring more than 3 cm is termed lung mass and should be considered indicative of lung cancer until histologically proven otherwise. Differential diagnosis of SPN, solitary pulmonary nodule. Dr. Konstantinos Lobedos et al. Summarized this as the title of Lung Nodules, a comprehensive review on current approach and management, Annals of Thoracic Medicine, year 2019, volume 14. Differential diagnosis of SPN is broad, very broad, and occurrence of relevant symptom is helpful, and the numbers of nodules will be helpful too, and the imaging characteristics such as location, shape, presence and type of calcifications, and presence of speculation or cavitation may narrow the differential diagnosis or even point toward the specific entity. Guidelines according to nodule size. Nodule size is strongly associated with probability of malignancy. First is less than 6 mm in diameter. This is acceptably low cancer risk, less than 1% of a possibility. Less than 8 mm is intermediate probability of about 1% of malignancy. More than 8 mm, this is important. This is high lung cancer probability of 9.7%, almost 10% possibility of malignancy. More than 8 mm is important. We need to memorize this number. Dr. Y would add one more thing about nodule size. Smaller the nodule size, fewer the nodule characteristics. So, less than 1 cm nodule shows only size, no other characteristics. Category of lung nodules depending on CT attenuation. Also, it was summarized by Dr. Konstantinos Lobedos et al. 1. Solid nodule. This is most common nodules, characterized by homogeneous soft-tissue attenuation. 2. Ground glass nodule. Non-uniform in appearance with hazy increase in local attenuation of lung parenchyma, not obscuring underlying bronchial and vascular structure. 3. Pot solid nodule, comprising both solid and ground glass attenuation components. Predictors of benign etiology. 1. Also summarized by Dr. Konstantinos Loberdos. Peripheral nodule, considered benign, most probably depicting intrapulmonary lymph node, except speculation or fissure displacement. Calcified nodules are generally not considered malignant, but 10% of lung cancer have calcification. Pattern of calcification: diffuse, central, laminated, and popcorn patterns are predictors of benignancy. Predictors of benign etiology. 2. Punctate, eccentric, and amorphous calcifications are indeterminate patterns that should not be preclusive of cancer. Fat attenuation is almost diagnostic of hamartoma and excludes primary lung cancer as a potential cause. Now, just enjoy the real cases of chest radiograph or CAT scan of pulmonary nodules. I'm sure that you are already familiar and a master of pulmonary nodules. So, Just enjoy the trip. Scenic drive. What will be about these nodules. What will be will be. What will be these nodules. Let's go. If you have reviewed the sessions I have recommended, then you are now already familiar with the nodules, true nodules. So now you can just enjoy another scenic drive of session 33, solitary primary nodule. Let's enjoy the trip. This one, 8 mm nodule on the middle-aged man. No classification, no specific findings of this nodule on CTs. This is tuberculous granuloma. Do you happen to remember? About 5% of tuberculosis manifest only single primary nodule. Old man, left upper lobe. Ovoid, 2 cm dense calcified nodule, densely calcified nodule on the magnified view. Dense calcification is the point of benignancy. It's tuberculous granuloma. Another tuberculous granuloma of middle-aged man, ovoid. This is not round, ovoid 1.5 cm nodule with rim calcification, concentric calcification, tuberculous granuloma. Another case of calcified tuberculous granulomas of a middle-aged man, collapsed right upper lobe, densely calcified nodule with a variable size of densely calcified nodules, all calcifications, no soft component, dense calcification of tuberculous granuloma. 1 cm retrocardial, left lower lobe, well-defined nodule in middle-aged women. In the coronal non-contrast CT, it's rim-like calcifications with a small fat density, so it's clear its calcification and fat means hamartoma. Another case of hamartoma, this one. Infrahilar area not overlapped with left inferior descending pulmonary artery, so not hilar lesion. Let's go to the CT axial image, non-contrast image. Soft tissue density surrounded by fat density. These are all fat densities. No uptake, no hot uptake on PET-CT. This is fat component. If it shows popcorn calcification, it is more clear to say it's hamartoma. This is sclerosing pneumocytoma of middle-aged woman. What is this nodule about 1 cm? Is this true nodule or pseudonodule of nipple? If it is true nodule, is it upper lobe or lower lobe? Not clear. This is the border zone. On enhanced CT, the 1 cm well-defined nodule is well-enhanced. Well-enhanced, sharp margin nodule beside the fissure, beside a major fissure. So this is left lower lobe perifissural sclerosing pneumocytoma with enhancement with perifissural location that suggests sclerosing pneumocytoma. He is a middle-aged man with colon cancer. There is a nodule, 2.5 cm, well-defined nodule in right lower lung zone. No characteristics, no characteristics to specify any type, any origin, just single. This is a just nodule, and sometimes colon cancer manifests as a single primary metastasis. This is only single nodule. How about this case? Huge, extensive, lobulating, contoured, conglomerated mass, probably lymph node conglomerated mass, possibly malignant lymphoma or small cell lung cancer. And we see another nodule here, 2 cm nodule here. On the axial enhanced CT, this is the nodule of probably primary point, primary site of small cell lung cancer. Itself does not have any characteristics, just nodule. We only imagine this origin because this conglomerated lymph node mass of small cell lung cancer. Small cell lung cancer primary site is just nodule. Non-specific findings of nodule. Let's move to GGN, ground glass opacity of adenocarcinoma. This is pure GGN, ground glass nodule with small bubbly lucency. This is the characteristics of adenocarcinoma, pure GGN, adenocarcinoma. How about this nodule? This nodule, somewhat ovoid, centrally dense, peripherally less dense, nodule or skull-like density. At the lung window axial thin section CT, we see the ground glass nodule about 2.5 cm, centrally more dense areas. So we call this as part solid nodule. This is the characteristic of adenocarcinoma, part solid ground glass nodule. How about this man's film? Not clear on the chest radiograph. On the CT, axial thin section CT, we see the same findings with the previous case. Part solid ground glass nodule of adenocarcinoma with fissure displacement or fissure retraction, or we call it puckering. This is adenocarcinoma. How about this image? This one. We are watching the growing history of maybe the growing pattern, growing history or aging of adenocarcinoma from pure ground glass opacity to part solid ground glass nodule, finally solid mass, solid nodule to solid mass. This one, 3 cm part solid, and pure ground glass nodule with bubbly lucency, with peripheral speculations. This is part solid GGN speculation, bubbly lucency, characteristic of adenocarcinoma. Now, this adenocarcinoma of middle-aged woman is more solid, no pure ground glass opacity, just solid mass with irregular margin and speculation. This is adenocarcinoma. Let's see another 1 cm nodule in old man. Clear nodule, 1 cm nodule. This is adenocarcinoma. Let's go to CT, thin section axial lung window setting CT. What do we see? 1 cm nodule with very tiny speculations. Sometimes we call this as corona radiata, sunburst. This is speculation suggesting malignancy. speculation. Another peripheral adenocarcinoma of 2.5 cm nodule, this one. At the CT, moderate enhancement. No specific characteristics on contrast to CT. Mediastinal setting image. And on this long window setting image, we see very tiny many speculations. The speculations suggest usually malignancy, aggressive growth pattern. This is left upper lobe adenocarcinoma of peripheral solitary pulmonary nodule. This may be the last slide of solitary pulmonary nodule adenocarcinoma, 1.5 cm nodule on the chest radiograph in right upper lobe. On the axial thin section CT of long window setting, this is a nodule with many speculations. We sometimes call this as sea urchin. You remember the sea urchin? Yes, sea urchin, very aggressive pattern of malignant growth. This is malignant. This suggests usually malignancy. This pattern suggests malignancy. This is adenocarcinoma of solitary pulmonary nodule. Have you ever tried the dish of Japanese dishes, sea urchin eggs? Sea urchin eggs? That's very delicious. It's yummy. Please try. How about this session? I hope you enjoyed this session. Actually, lung nodule, solitary pulmonary nodule is almost everything about chest radiology because chest radiology is always alert about lung cancer. Solitary pulmonary nodule is the beginning of lung cancer. And now I congratulate your effort and you became the master of lung nodules. Congratulations again. Like, subscribe will be a good support and will make your next session wonderfully by Dr. Y. Thank you very much and have a good day.